Thanks so much, Dennis. It's an honor and pleasure to be here today to talk about TBI and ICP management in austere environment. I'm currently a neurointensive care fellow at Duke University Hospital in Durham, North Carolina. I have been in the Army for just under 9 years now, and I did my residency at Madigan Army Medical Center in Fort Lewis, Washington. I was briefly assigned to Womack Army Medical Center at Fort Bragg before deploying with the 82nd Airborne in 2014 to Afghanistan. Came back and then was fortunate enough to begin my training at Duke in intensive care neurology, and we'll be returning to the active duty pool here in the next couple of months. So today we're going to be talking about traumatic brain injury, and specifically traumatic brain injury and its management in austere environments as part of the prolonged field care paradigm that's been growing over the past couple of years. And I should start by saying that the topics that we're going to discuss today are currently in a draft format. And will be appearing as clinical practice guidelines, hopefully within the next couple of months, late summer or fall. So a lot of what we'll talk about here today, you'll see in the future in a publication. And I should also add that traumatic brain injury and ICP management is a rapidly evolving field. So what gets published will likely evolve probably in short order and certainly over time. As new therapies become available and we get more and more data. Neurocritical care, TBI management is really a young field and one that's constantly changing as we get more and more information by studies that are being conducted. But the purpose of this talk today and of the clinical practice guidelines is to present you with the best available guidelines and recommendations for TBI management. And give you some tools to assess and manage these patients in the field as you come across them. So this slide here is showing us the DoD numbers for traumatic brain injury worldwide, and this was updated in November of 2016, and it's regularly updated by the Defense and Veterans Brain Injury Center. So you can see the most recent ones on their website online. And what you'll see here is that the overwhelming majority of traumatic brain injury is mild in nature. And while that's a very, very serious condition and one that warrants its own discussion, what we're going to focus on is actually the moderate and severe traumatic brain injuries. And fortunately, they occur in much smaller percentages than the mild format. But these are the folks that are at serious risk of severe disability and or mortality in the field. And these are the folks that we want you to be able to intervene on and maintain for as long as possible until you can get them to more definitive care. So moderate and severe, and especially severe traumatic brain injury, historically has been plagued by pretty discouraging data. The numbers that I've put up here are specifically related to penetrating traumatic brain injury, which is a severe form of traumatic brain injury, though they can oftentimes be attributed to blunt injury as well. And as you can see, the numbers are pretty grim. 70 to 90% of patients will actually die before arriving at the hospital, and half of the patients that get to the hospital die during attempts at resuscitation in the emergency department. And even if they do survive that initial resuscitation, the likelihood that they are going to undergo some type of neurosurgical procedure like decompressive hemicraniectomy is very low. In civilian trauma centers, as of a paper from 2014, only about 20% of patients who reach the trauma center will actually undergo some type of neurosurgical procedure, particularly in the severe TBI category. And there's a lot of literature that is available that lists the indicators of poor prognosis, and among them is a low post-resuscitation GCS, usually somewhere between 3 and 5, patients of older age, large and unreacted pupils or pupillary asymmetry, and then the presence of hypotension defined as a systolic blood pressure less than 90 millimeters of mercury, or hypoxia defined as a PaO2 of less than 60 millimeters of mercury, are associated with twofold increases in mortality from if you have either one of those or both in the time from that the patient sustains the injury to resuscitation in an emergency department. But with some of the data that we've compiled in theater during the recent conflicts, there is some reason to be optimistic. And one of the papers that came out a couple of years ago was comparing the Joint Theater Trauma Registry TBI patients, or about 604 of them, to a number of matched TBIs in the civilian data bank, or the Surgeon National Trauma Data Bank. And it showed improved mortality among military TBI casualties as compared to civilian TBIs. Overall, there was a significant difference, and it was especially notable in the penetrating category. And some of the authors had concluded that the strong emphasis on the prevention of secondary brain injury in the pre-hospital setting, the immediate availability of medics, for example, may have been one of the deciding factors behind the improved mortality in the military TBI patients versus the civilian. The other factor that seemed to play a role was the high rate of neurosurgical intervention that occurred in the military patients as opposed to the civilian patients, where there's still sort of a grim outlook on patients that present as severe TBIs. Another paper that had been put out actually specifically looked at this, and this was a number of military neurosurgeons, and they looked at 137 patients again with penetrating TBI, and 31 of those patients had a GCS of between 3 to 5, so in the severe category. But what was really interesting was that 32% who had presented with that initial GCS score of 3 to 5 had a Glasgow outcome score of greater than or equal to 4 after 2 years, which means that they were essentially functionally independent after they had undergone aggressive neurosurgical management. The point is, I think that these folks, if they don't die, and again, it's important to recognize that these are very serious injuries, and many of these patients will, despite your best efforts, die in the field. But those that you can get through, or who make it through the initial injury, with the proper management and the expedited evacuation to a higher level of care, can actually have an improved or a meaningful outcome, either surviving the injury or potentially having a markedly reduced disability. So the prolonged field care clinical practice guidelines are going to focus on a number of different aspects of TBI care in the austere environment. It's going to focus on the rapid assessment and triage of traumatic brain injury patients. We'll talk about that today, as well as different management options with regard to hemodynamic management, airway, ICP or intracranial pressure, infection control, seizures, and sodium management. And then lastly, we'll talk a little bit about some transport and evacuation considerations, and then some questions about invasive procedures that are sometimes done in these patients, and whether or not they're appropriate for the prolonged field care situations or Role 1 facilities. We'll start with assessing ICP. And TBI severity is divided up into, or can be defined a number of different ways. One of the most common is by imaging, which is probably not going to be available to you in the prolonged field care setting. The other ways in which traumatic brain injury is defined can depend on the duration of loss of consciousness, the period of time that the patient has an altered level of awareness, or the period of time in which they suffer from a post-traumatic amnesia. A lot of this is useful in an academic sense, but when you're dealing with somebody who has a traumatic brain injury, especially a moderate or severe one right before you, they're probably not going to be all that helpful, and they're certainly not going to be something that you can use to gauge injury severity at the time of or shortly after the time of injury. Much more useful is the Glasgow Coma scale, and I think that this is something that everybody should know how to calculate quickly and accurately. And it can be done relatively easily at the same time that vital signs are being obtained. What's important to note is when you initially assess your injury, your TBI, and you calculate your GCS, you should also obtain a post-resuscitation GCS. Sometimes some simple interventions involving blood pressure, oxygenation, fever if it's a little bit later in the course of the injury. Sometimes simple interventions that address those problems can have drastic or result in drastic improvement in your patient's GCS. So keep that in mind, that the initial GCS that you calculate compared with the post-resuscitation GCS may be significantly different and worthy of noting. The GCS will also help you determine whether or not a patient is getting worse and whether or not you should think about instituting some of the other management interventions that we're going to discuss in the rest of the talk. So in addition to the clinical exam that you do, obtaining the GCS, performing a neurologic exam on the patient, which includes cranial nerve exam, a motor exam, and potentially reflexes and sensory, though certainly the cranial nerves are the most important of the group. There are also a number of non-invasive ways to measure ICP. Lumbar puncture, for anyone who's ever done one, is certainly a means of obtaining an intracranial pressure. But one, it's non-invasive, and two, you don't want to do that in an individual when you don't know exactly what's going on inside the skull. In the setting of increased intracranial pressure, the lumbar puncture could actually result in a herniation syndrome and leave you in a sticky spot with regard to management and make the patient worse. So it's generally recommended that even if you know how to do this, that you stay away from trying to stick any needles into the back. Pupillometers are a more and more popular tool that are fairly cheap and easy to come across, including some apps that are available on phones nowadays. And they're better at detecting small changes in pupil size. Once you start using medications to address pain, and when you start trying to sedate the patient, some of the meds will actually have an effect on the size of the pupil, and it can be very difficult, particularly with narcotics, for example, to assess the change in a myotic pupil that results from the drug effect. In a normal individual, there's typically about 33% change in size with your swinging flashlight exam, but in an individual whose ICP gets above 20 millimeters of mercury, that change in size can decrease to as little as 10% or less. So it can become very, very difficult to assess that with the naked eye. Pupillometers, therefore, are a potential tool to help you do that, and utilizing the pupillometer to determine the degree of change, the rapidity of the change in the pupil size can sometimes give an indicator as to whether or not the patient is developing elevated ICP or worsened elevations in ICP. One of the most useful tools, I think, for providers in the field is the ability to use ultrasound. Ultrasound in emergency medicine and critical care has really taken off in the past couple of years, and the ability to assess for intracranial pressure using optic nerve sheath diameter measurements is particularly useful in these particular circumstances. There's a couple of slides, and I'll talk about this in a little bit more detail here in just a moment. But optic nerve sheath diameter is something that is you can quickly become proficient in and may aid you in your clinical assessment in determining whether or not a patient is developing or has elevated ICP that needs to be intervened on. And in the future, there may be an easier way to utilize modalities such as transcranial Doppler, but at the moment it's a little bit too complicated, and it's not accurate enough to really determine or help you assess for ICP. So it really doesn't have a role in current ultrasound assessment of TBI and ICP. For the neurologic assessment, then, the goal is going to be to rapidly identify the clinical signs and symptoms of TBI and any associated trauma, and then to assess TBI severity. There are a number of red flags such as headache, nausea, vomiting, focal neurologic deficits, meaning weakness on one side of the body, weakness in the face or the arm, or weakness in the leg, for example. That should key you into the fact that there is likely some underlying brain injury as a result of the trauma that the patient has sustained. The best way to assess for this is to do a detailed examination, to include a detailed neurologic exam plus the optic nerve sheath diameter measurements. The better way to, or the next step down, or the better category would be to do a detailed neurologic assessment, and then to do at least an abbreviated pupil exam and potentially a fundoscopic evaluation. I'll talk about that here in just a moment. And then at the bare minimum, the rapid trauma assessment and the calculation of a GCS and the APU score, as well as assessment for TBI red flags and documentation of any red flags that you find, is recommended. With regard to fundoscopic evaluation, there are a number of cheap and fairly easy to use ophthalmoscopes that can fit into pockets nowadays. They're about the size of pens almost. And learning how to look at the back of the eye is critical to a neurologic assessment. In residency, we always used to say that the eyes were the window to the brain. And assessing for abnormalities such as papilledema or swelling of the optic disc, or something called spontaneous venous pulsations, which are just small pulsations of the retinal veins, can give you a great idea about whether or not the patient is experiencing high pressures as a result of their traumatic brain injury. This slide here shows you the difference between a normal optic disc and the vessels that arise from it on the left side, as compared to a patient with high pressures on the right side. And you can see that the optic disc margins are barely perceptible in this image on the right side, and the vessels that are emanating very clearly from the normal picture on the left side are very difficult to distinguish. And a quick fundoscopic or ophthalmoscopic exam can reveal these findings for you, and in the right setting can support your suspicion for high ICP. The large vessels that you kind of see at your 12 o'clock and your 6 o'clock on that picture on the left are actually the retinal veins that I was just talking about. And there's really, really good data that shows that if you look in the back of somebody's eyes and you see those veins pulsating, then it's really not possible for the patient to have an ICP that's above 20 millimeters of mercury. Conversely, if the patient does not have venous pulsations, that really is of no value to you. But if you see them, you can rest assured and be relatively certain that the patient that you're examining does not have elevated intracranial pressure. And serial examinations looking for that finding can sometimes be helpful. This image is a depiction of pupillary asymmetry, which is again a key finding in a patient who has traumatic brain injury. And the right pupil is quite clearly larger than the one on the left side, and that difference in pupil size is really a strong indicator, particularly in the trauma patient, that there is brainstem compression or compression of the third nerve specifically occurring, likely as a result of edema, and shift the brain tissue to compress that nerve. This is a very alarming finding and requires immediate intervention, where the patient you're likely going to lose your patient as a result of herniation. There are other softer findings that can sometimes be appreciated. On the previous image, you saw what was called raccoon signs, or the ecchymosis and the bruising around the eyes. This image shows you what's called battle sign, and it results as a function or as a result of the damage to the posterior auricular artery or rupture of that artery, and it is typically associated with a skull fracture. And oftentimes with skull fractures, if the patient is subjected to enough force to fracture the skull, there's likely some type of underlying brain injury, whether it be a hematoma of some sort or direct injury to the brain tissue itself. So examining the patient and looking for these types of findings can also be helpful. This image is a quick depiction of how to utilize the ultrasound to assess for optic nerve sheath diameter, and it's really quite simple. All you need is the ultrasound machine and a linear phased array probe, which is the same probe that you use to look for vessels when you're attempting to cannulate vessels, IVs, and the like. And it's placed in a horizontal fashion over a closed eyelid. And you basically look for a dark shadow in the posterior aspect of the eye that would represent the optic nerve in the optic nerve sheath. This image depicts what you would see on ultrasound, and you can appreciate the eye or the vitreous in the middle of the screen is that dark circular area. And then posterior to that is the optic disc, and all you really need to do is measure 3 millimeters back from the optic disc, and then take a transverse diameter of the optic nerve and the optic nerve sheath. And typically, depending on what you're reading, a diameter of 5 or 5.5 millimeters or greater is associated with elevated ICP. In practice, however, there can be a very wide range of normal diameters. So in and of itself, I'm not sure that a one-time on-the-spot optic nerve sheath diameter measurement is necessarily going to help you identify ICP. I think this exam is much more valuable if it's done serially or repeated over time to assess for changes in the optic nerve sheath diameter, or to look for a significant asymmetry in the diameter between one optic nerve and the other, which those I think would be much more likely to key you into increased intracranial pressure in a TBI patient. So we'll move on now and talk a bit about management, and we'll start with hemodynamic management. And hemodynamic control is probably the most important thing for you to address in a patient who's had a traumatic brain injury. Control hypotension before controlling intracranial pressure. There is a desire in a lot of people to jump right on top of the ICP and want to give osmotic therapy or other interventions that specifically address ICP, but you're much more likely to improve cerebral perfusion pressure, which is the difference between MAP and intracranial pressure, if you address low blood pressure than you are addressing the ICP. Not to mention that hypotension is usually not due to traumatic brain injury itself. If it is, it's typically very late in the course of it when you begin to develop medullary compression from increased swelling and herniation. Oftentimes, however, if you get to the patient early and they're hypotensive, make sure that you look for an alternate source of blood loss, since that's much more likely to be the cause, particularly early on. And as mentioned earlier, a single recorded systolic blood pressure of less than 90 millimeters of mercury from the time of injury to resuscitation increases the odds of death by 2.62 times. So this is a very serious issue, and it needs to be addressed promptly in your traumatic brain injury patients. The minimum approach, or the very least that you want to do, is stop the bleeding if you can identify a source, and that can be done through direct compression, through tourniquet use, and then through TXA as well. The next step, or the better recommendation, would be to give an isotonic or a hypertonic fluid. And it should be noted that when you give fluids, if at all possible, avoid hypotonic solutions, which include lactated ringers, since the hypotonic solutions can actually worsen cerebral edema. If resource limited, however, and you don't have anything other than something like LR, then I would say give what fluid is available to you. Although certainly common saline or 0.9% sodium chloride, or even a hypertonic, if you've got one of those solutions, would be preferable. But if you are addressing blood pressure issues and you need to try to get that pressure up, and that's the only fluid you have, then you can deal with the swelling later on. And the best method is to actually go with a blood transfusion to replace the lost volume and potentially to optimize O2 delivery. And then if you are able to get access to pressors, which is probably unlikely in the PFC setting, those can also help you maintain mean arterial pressures and maintain cerebral perfusion pressure in the setting of high ICP. Airway management should be the next facet of the TBI patient that you address, and at the very minimum, you are probably going to want to support them with positive pressure ventilation using a bag valve mask at a rate of 10 to 12 breaths per minute. Better than that is of course the cricothyroidectomy or the LMA placement if the patient has absent brainstem reflexes. And once you get your cric in place, you're going to want to target an SpO2 of greater than 90%, and the use of end-tidal CO2 monitors is more and more prevalent. They're fairly easy to take with you and to apply to these patients. You're going to want to target an end-tidal CO2 of about 35 to 40 millimeters of mercury. And then in the best case scenario, if you can get your hands on a ventilator, attaching the patient to a vent and using lung protective ventilation, again targeting an ET or an end-tidal CO2 of 35 to 40, and a PaO2 of greater than 80 or an oxygen saturation of greater than 95%. You'll notice that those numbers are a little bit higher than some of the numbers that I had given earlier. And I think that a PaO2 of greater than 60 or an SpO2 of greater than 90 are minimum and better recommendations. But there's more and more data that's available now that says that targeting those higher numbers may actually improve outcomes in TBI patients. So if you can get the patients to those types of numbers, that's certainly ideal as compared to some of the minimum recommendations that we provided earlier. We'll talk a little bit about the management of elevated ICP at this point, and the goal here is to rapidly recognize and manage intracranial hypertension, and to maintain an adequate and stable cerebral perfusion pressure as much as possible. So once again, hypotension is more important than ICP, so address that first. But if you've adequately addressed that and you feel like that's stable and you're still concerned about intracranial pressure being elevated, then we're going to talk about how to address the cerebral edema that's likely resulting in the increased intracranial pressure. So at minimum, you're going to want to utilize general measures to prevent and control further elevations in ICP. And in the setting of elevated ICP, without any other means available to treat it, hyperventilation can be used for brief periods. This used to be much more common, but it's really fallen to the wayside now because people were doing it for prolonged periods of time, and they were actually shifting from high ICP and as a result of cerebral edema from the vasodilatation that the high levels of carbon dioxide were causing to actually constricting the vessels and causing additional secondary injury from vasoconstriction and ischemia as a result of pushing the CO2 levels too low. So in a pinch or in the absence of any other type of intervention, the use of hyperventilation is fine. I generally recommend that you try to confine it to less than 10 minutes. It's definitely effective, but it can do more harm than good if it's used for prolonged periods. Other simple interventions that can be made is elevating the head of bed from about 30 to 60 degrees. A lot of patients we tend to keep in a supine position, but your head injury patients, you actually want to lift the head of the bed up, again, 30 to 60 degrees. And that helps facilitate venous drainage from the intracranial spaces and keep ICP at a minimum. Keeping the neck in a midline position. A lot of these patients are going to probably end up in C-collar, so you usually don't have to worry about that too much. But if for some reason you don't put them in a C-collar, keep the head and neck in a midline position, and that will also facilitate venous drainage from the skull. As we talked about earlier, maintaining a PaO2, if you have the ability to measure that, greater than 60, and an oxygen saturation of greater than 90. Those are the minimum goals. Again, if you can get them above 80 and 95% respectively, that's even better. Maintaining a PaCO2 or an end-tidal CO2 between 35 to 40 millimeters of mercury. Maintaining core temperature is also important, and most of you are probably aware that hypothermia is one of the big killers on the battlefield. But you have to be careful in brain injury patients with letting the temperature get too high. And remember that the temperature in the brain is slightly higher than what you're going to measure in the rest of the body. So keeping the temperature between 35 and 37.5 degrees Celsius is likely the target temperature for a brain injured patient. And of course, you have to balance that with other injuries that they sustain, but keeping them on the cooler end is better for preventing secondary injury in the setting of TBI. Glucose levels. Most everyone carries the little portable glucometers. Trying to keep glucose levels between 80 and 180 milligrams per deciliter is ideal. I think targeting or preventing hypoglycemia and certainly a glucose level below 60 to 70 is very, very important, since the brain utilizes glucose to keep its cellular machinery running. Is going to help increase the likelihood of your patient having a good outcome or not dying in front of you. And rapidly managing any type of seizure activity, since seizures can elevate intracranial pressure. And bear in mind that sometimes seizure activity can actually occur in a non-convulsive presentation. In other words, non-convulsive status epilepticus. So if you have a patient that's really not improving, or who you think should be waking up and is not, always keep that in mind. And if you're worried about high ICP in that setting, then we'll talk about that here in a few minutes. But always think about seizure in these patients and addressing that early and often. So the better approach is to address elevated ICP is to think about bolusing any analgesic medications that you have available to you. And specifically your narcotic pain medications or your ketamine. I would avoid any type of nonsteroidal agents in these patients, since they have an antiplatelet function associated with them and can theoretically worsen any type of bleed that's occurring that you may or may not be aware of in your TBI patients. But bolusing analgesic medications is certainly the first line intervention that we use at the hospital that I practice at. And the idea here is that a patient who is agitated or in pain is probably not going to be cooperative with what you want to do, or even if they're relatively calm or calm appearing, if they're hurting, then that's gonna raise any intracranial pressure problem that they're currently experiencing. So giving these types of medications and considering them, particularly when you're going to move a patient as well, is I think going to be key to helping manage ICP in the prolonged field care setting. This slide here is just a quick depiction of the physiologic state of cells under both normal conditions or without high ICPs, and then both in situations where the ICP is high and when the ICP is low. And really what I want you to understand looking at this slide is that the therapies that we're going to talk about next, which are the osmotic therapies, are designed to pull fluid from the brain tissue and shrink those cells and therefore decrease edema. And what you want to avoid is the picture on the right, where you have significant cell swelling, since cells will either die or undergo a type of cell suicide under these conditions. And these are certainly the conditions in which intracranial pressure is going to rise. So the best therapy for your elevated ICP patient is going to be to administer osmotic therapy. And I think the first choice is hypertonic saline for a number of reasons. And what's most widely available to most of you is probably going to be the 3% concentration, which it's commercially available, so it's easy to purchase. And typically you're going to administer about 250 milliliter bolus over a 15 to 20 minute period. And you can repeat that every 3 hours as needed for high ICPs. There are some institutions and there are some situations where a hypertonic saline infusion is run, and it's just as good as administering as a bolus. But since you're likely going to have limited resources, I think the best thing to do is to stick to bolus dosing in order to conserve what you have available to you. As a second choice, I think mannitol is your next bet or your next option. And mannitol is given as an initial dose or as a bolus dose of 1.5 grams per kilogram. It can go IV or IO. And then subsequent doses can be lowered somewhat to 0.5 grams per kilogram, also IV or IO, and it should be pushed over a 15 to 20 minute period, and it can be dosed every 3 hours as well. Hypertonic is, I think, preferred largely because it does help maintain or improve intravascular volume through its osmotic effect. So in a polytrauma situation, in addition to the ICP lowering effect, it may actually help you address hypotension. Whereas mannitol is a diuretic, and it can result in a pretty profound diuresis, and you're going to end up fighting yourself if that's the case when you're trying to address hypotension in your patients. Both of them are effective at lowering ICP. So if you have one but not the other, specifically if you have mannitol but not hypertonic saline, it's fine. But in general, I think hypertonic saline is the preferred agent in these situations. And there are a number of other medications that have been used to address high ICP in patients. There's a couple of papers looking at some case series or a very limited number of patients with some agents like sodium bicarbonate, which a lot of the medics out there will carry. But I think before using any of those agents, you should seek medical direction from a neurosurgeon or a neurocritical care specialist, since the data behind those is limited, and at least theoretically there can be some harm that can be done to your patients by administering those agents that don't have as much evidence behind them. We'll talk about infection control next, and your goal here is to dress your wounds to prevent further exposure to environmental pathogens, and then administer antibiotic prophylaxis specifically to all open or penetrating traumatic brain injury patients. So for open or penetrating TBI, the best agents that you may or may not have available to you out there are going to be cefazolin or ceftriaxone, since they have good and well-documented CNS penetration. And then if the wound is contaminated with organic debris, adding metronidazole is certainly an option. And the use of ertapenem is a big question mark, since that's a common agent in the field nowadays, because it covers so many different types of pathologic organisms. The problem with ertapenem is that it's the data supporting its CNS penetration is lacking at this point. And there's not a lot of good information about whether or not it can get to the brain tissue the way you would want it to. So until that evidence is available, it's hard to recommend ertapenem as a first-line agent. On the other hand, if you're in a situation where you don't have some of these other agents that I've been talking about, and that's all you've got, and you want to get as many pathologic organisms covered as you possibly can, I would say go ahead and use ertapenem, since we certainly don't have evidence that says that it cannot get into the brain. We just don't have enough right now that says that it effectively does. So I would say go ahead and use the ertapenem if you've got nothing else, and hopefully in the near future we'll have more data about its application in these types of CNS injuries. Antibiotics, it should be noted, are not necessary in traumatic brain injury without penetrating trauma. The only other consideration, or the only other time that you might take a patient who doesn't have an open or penetrating injury to the brain is when there's a significant penetration into the sinus cavities, since you can't rule out subsequent penetration into the intracranial cavity, and those are very dirty spaces and are at high risk for causing a CNS infection. So, but in general, if you can rule that out, or if you've got somebody who does not have an open or penetrating injury, you can save the antibiotics for another time or for another patient. And as a minimum, in these patients, you're going to want to dress all the wounds to prevent any further wound contamination. And one thing that I would caution you to stay away from is introducing any material into the wound cavity that's not absolutely necessary. So I wouldn't pack those wounds, since you're not sure exactly what's underneath that, if it's close to a sinus or a significant blood vessel, or irrigating with anything that's certainly with anything that's not sterile. I think that's best left to the surgeon to do, and I would recommend against trying to put anything into the inside of the skull in the event of an open or penetrating wound. we'll talk for a few minutes now about seizures, and the goal is to, as best as possible, rapidly identify and manage seizure activity in TBI patients. And as previously noted, seizures can raise ICP, so keep that in mind if you've got a previously stable patient and all of a sudden you have changes in their exam and you're concerned about their ICP increasing. And as a minimum, for a witnessed or suspected seizure, you're going to want to use lorazepam or midazolam. And the doses are a little bit higher than I think a lot of times what we typically use to calm or sedate patients. And a lot of this comes from fairly recent literature about addressing status epilepticus or a state of continuous seizure with benzodiazepines. And what you really want to do is you want to saturate those benzo receptors in the brain. So if you've got a patient who's seizing, hitting them with 5 to 10 of midazolam IV or IO, or 4 milligrams of lorazepam IV or IO is what the current literature is recommending to stop those seizures. The catch here is that when you administer higher doses like that, you're likely going to get a pretty significant sedation that occurs as a result. So it can impair your ability, particularly with a longer-acting agent like lorazepam, to do your subsequent neuroexamination. So keep that in mind if you've had to use that medication or it's been administered recently. But I think in the setting of a seizure, particularly in a TBI patient, you're going to want to go ahead and do what you can to stop the seizure activity. And then as a best recommendation for witness seizures, you're going to want to add to your benzodiazepine, if available, a longer acting agent such as levetiracetam as a 1500 milligram load, and then 1000 every 12 hours. There are certainly other agents that might be more readily available in some of the countries that we would expect to be operating in, like phenytoin. And I would address that question depending on what type of anti-epileptic drug is available to your consultant and regarding its use in your patient. The other thing I think is worth noting is that it's really important, I think, to consider prophylactic seizure treatment prior to transportation or movement. One of the last things that you're going to want to have to deal with is a patient who starts seizing when they're in the back of your truck and you're trying to move them or in the air. Since this can present a real significant problem, not only in regard to ICP, but it can create airway issues as well, or oxygenation or ventilation issues. So really consider before any significant movement dosing the patient with midazolam or lorazepam to try to head off this problem before it becomes an issue for you. Hypothermia, like we talked about earlier, we're gonna set a goal of maintaining a core temperature between about 35 to 37.5 degrees Celsius, and you're going to want to treat hyperthermia aggressively in traumatic brain injury patients with a combination of different therapies. The best approach would be to, if available, is to use acetaminophen or Tylenol, and that can be administered as a tablet, either PO if the patient is able to take PO, or per rectum is probably the other likely route of administration. And cold saline boluses can be used as well if you're able to cool down the any fluid that you have for refractory hypothermia as well. The next level down, or the better category, would be to apply cold packs to axillary regions, posterior cervical regions, and the groin. And if available, things like ice baths can be considered. But what you want to be careful of is inducing rapid cooling and shivering, which can increase ICP. So if you end up using an ice bath, just be very, very careful about doing so, since you don't want to create one of the problems that you're trying to solve. As a minimum, getting the patient into a cooler environment and utilizing surface cooling measures to reduce core body temperature and inducing evaporative loss by misting or fan cooling. These are the bare minimum interventions that you should be making in a patient that you think has TBI and is hyperthermic. Sodium management. The goal here is, as alluded to earlier, to avoid hyponatremia, which will increase tissue swelling in the brain. And if you have the ability to test for this and to get serum sodium levels, then targeting a serum sodium between 135 and 145 millimoles per liter is appropriate. And when hypertonic saline is being used, then generally you're going to want to target a serum sodium less than 160. As you can imagine, giving hypertonic solutions is going to increase your serum sodium levels over time. What you don't want is for them to get to a dangerously high level, which is generally considered to be 160 or more. So if you have the ability to monitor and measure that, great. If not, then once again, I think in the absence of that type of information, then you just treat what you have in front of you. And if you have ICP and an osmotic agent to treat it with in front of you, then go ahead. But if you have access to labs, then this can help guide your therapy as well. So as a best recommendation, you're going to want to check, if you can, sodium labs via regular lab draws. Generally every 6 hours is appropriate. In an unstable patient, you may want to do it a little bit more frequently. If you're giving hypertonic saline every 3 hours or so, as we talked about earlier. And then adjust any fluids as needed to meet the patient's established sodium goals. So this is an instance where if you are checking labs and your levels are high, you may want to balance those high levels with the administration of something that's a little more hypotonic, like LR. But I think in general, as stated earlier, you're going to want to stay away from those types of agent or those types of solutions. And if you run into a situation where you're trying to balance your sodium goals with the fluid that you're administering, seek expert medical advice in doing so. The next level down, or the better category, would be again to use 0.9% sodium chloride as boluses or as an infusion, again to keep your serum sodium levels between 135 and 145. And then as a minimum, you're going to want to avoid the administration of any free water or as we talked about earlier, hypotonic fluids that will lower serum sodium levels. A brief note on surgical procedures. So it's come up a couple of times in the course of my career and even recently talking about the clinical practice guidelines for TBI about whether or not non-surgeons or non-neurosurgeons specifically should be attempting invasive procedures such as burr holes or ventriculostomy. And I think the consensus, certainly at this time, is no. There's certainly harm that can be done by performing these procedures without training and experience. Not to mention that if you're in a situation in the field and you're thinking that your patient needs a burr hole or a ventriculostomy in order to save them, then the likelihood of that actually giving you any benefit is probably very, very low. So I think at this time, as interesting as they are, if you can't get those done earlier, you can't get them to an individual who knows how to do them, I think it's best avoided. One of the questions comes up is if I can get the patient to a non-neurosurgeon, is there anything available that the non-neurosurgeon can do? And interestingly, there's some data that comes out of UMM from a guy named Thomas Scalia looking at decompressive laparotomy as an option. And the idea here is that you're lowering or opening the compartments in either the thorax or the abdomen to decrease peak airway pressures, and that seems to have an ICP lowering effect. There's a lot of debate about whether or not this can or should be done. It's certainly not something that I think is something that should be done or tried in the field or even in a Roll 1 facility. But if you are able to get the patient to a surgeon, then it's certainly something that's worth discussing, and it may be something that we discuss more and more as TBI management evolves. And then for transport, once again, I think it's important to pre-medicate patients prior to any significant movements. One of the other considerations is sometimes you're very pressed for space when you're moving a patient, but if it's at all possible, I think it's important to keep that head of bed elevated to 30 to 60 degrees as you're transporting the patient, whether that's ground or air. It's really going to make a difference for you, and I think and help you keep ICPs stable or certainly to prevent increases in ICP by facilitating that venous drainage. And then always tell any aeromedical evacuation asset that you have or that you're operating that you're going to be moving a patient who has significant brain injury. Once you get up into the air, especially if you're in a vehicle that it travels at higher altitudes, you have to be concerned about the effect of low pressures on oxygenation or what we call hyperbaric hypoxia. Once you get above 8,000 feet, there's a low incidence, fortunately, but certainly a risk for something called HACE, or high altitude cerebral edema. And your flight medics should have information about that and be aware of it, but just make sure that they're very clear that you have a moderate to severe TBI patient that you're transporting, so that they can make any adjustments to their flight plan or to their care plan that are necessary. So that concludes the discussion on traumatic brain injury in the austere environment and in the prolonged field care setting. Thank you very much for listening.